What you've heard today so far, if I can summarize it, is the people who are experts in the field talking about the technical aspects and the historical aspects of neuroendocrine tumors. I'm going to change gears a little bit here and talk about the outcomes of the surgical cytoreduction of neuroendocrine tumors. And as a little added lagniappe, for those of you who don't know what lagniappe is, if you're in New Orleans and you go and buy like donuts, you don't get a baker's dozen, you get lagniappe. That 13th donut is lagniappe. So for lagniappe today, before lunch, we're going to talk about the comparison of how you preoperatively manage a patient with a neuroendocrine tumor. Do they need an octreotide drip, or can you do a single isolated dose like Dr. Pommier does? We'll see. First of all, I'd like to acknowledge a whole bunch of folks here from surgery, from anesthesia, from our School of Nursing, Annie Diebold, who put together a lot of the numbers here and did some of the statistics. Our group at Ochsner Medical Center in Kenner, and a whole bunch of folks that without them we couldn't do anything when it comes to our research. Again, the background, just to again reminding you that the neuroendocrine tumors differentiate along multiple pathways. There are peptide-secreting tumors, and those peptide-secreting tumors are things like the pancreatic beta cell that make insulin and C-peptide, the delta cell that makes somatostatin, the alpha cell that makes glucagon, the pancreatic polypeptide cell that makes PP, the vasoactive intestinal peptide cell that makes VIP, and the gastrin cell, the G cell of the gut and the pancreas that makes gastrin. In the opposite thing, the thing that we deal with most commonly, about 70% of the time you heard, are amine secretors. And those amine secretors secrete things like serotonin, they secrete histamine, they secrete bradykinin, and there are also cells like in the adrenal, the medullary cells that make epinephrine, norepinephrine, and dopamine. Again, just a quick review. Again, what you heard from Dr. Shi was that tumors should be stained for Ki-67, chromogranin, synaptophysin. Dr. Odorisio and his team had a study for many years, don't know whether it's still going, where they stained somatostatin receptor subtype 2 and subtype 4. Actually, my mother's tumor was part of that study and stained positive for SST2. And they're using that to predict whether you'd be an Octrea scan candidate, et cetera. Again, you've seen this. Dr. Wang showed you this. This is our 2,000 patients that we have electronically put into a database at the Nolanets location in Kenner, Louisiana. Again, what we're going to talk about today are mostly the midgut tumors over here, and we're going to talk about survival after you resect the primary tumor, take out the lymph nodes, and start to cytoreduce the liver. Again, if you look at the numbers, ileum, jejunum, and small bowel are about 35–40% of all the tumors that we deal with at our institution. And ultimately, we believe that it's the fact that there's not just a surgeon at the Nolanets. We have 4 gastroenterologists. We have Dr. Campo, who's our nuclear medicine guy. We have a dietitian. And it's that multi-specialty group that we think makes a difference. But at least a major part of what we think increases the survival of patients who come to us is that we are aggressively go after and proactively resect the primary tumor, the lymph nodes, and cytoreduce the liver and anything else we can cytoreduce. Dr. Maudlin, who's not here, thank goodness, because Dr. Maudlin and I never see eye to eye about anything, but that's all right. Everybody's has an opinion. His just happens to be wrong. Said that there's nothing that's been progressing or nothing that's been happening for the last series of decades to improve the survival of midgut neuroendocrine tumors. And he quotes that there is a 5-year survival of 40%-ish, and that hasn't changed since Noah built the ark. Dr. Maudlin, you're wrong, and I'm going to show you the data. So there are not just work from us, this is work from the NANETS group, which is the North American Neuroendocrine Tumor group, Dr. Turga and his group, Garcia and Carbonara, Bill Moore, and Dr. Boudreau when we weren't really NOLA-NETs. We had just formed our group after Katrina. Everybody talks about what a terrible thing Katrina was, but the one thing Katrina did was brought us together to practice in a multi-modality, multi-specialty group. But you can see that these are a little bit better than Dr. Maudlin said, 40% median survival, and that's just way under. If you look at our overall taking people who've been operated on, haven't been operated on, put the whole Megillah together, you can see that the 10-year survival rate of patients with regional disease, that means they had a primary and lymph nodes but didn't have distant disease. You can see that at 10-year survival that we had 81% and 92% 5-year survival rate. If you looked at the distant people, who are the people with distant disease, you can see that the 10-year survival rate in this group, surgery and not surgery, is 63%, whereas the Maudlin data was 30%. So we have about, if you look at this group and look at this group of numbers and you do the math, it's about double what Dr. Maudlin said. So, Irv, first evidence, you're wrong again. And then the second question that I put out to the group is, how do we change the 5, 10, and 20-year survival rate in well-differentiated small bowel neuroendocrine patients? And the answer is surgery, surgery, surgery. It's just like real estate. How much is your house worth, and where do you buy a house? It's all location, location, location. For survival in neuroendocrine tumor patients, it's surgery, surgery, surgery. And so we're going to talk about well-differentiated neuroendocrine tumors. They're rare, slow-growing tumors. The majority of them rise within the GI tract. Dr. Warner told you that. And I showed you, and Dr. Wang showed you the distribution of jejunum, ileum, and proximal colon. Survival depends on the location of the primary, the extent of nodal involvement, and the presence of distant metastasis. You heard that today from Dr. Hsu and from other people. What do? Well, we aggressively surgically cytoreduce people. Everybody says that's surgery. Well, yes and no. Surgery is a critical issue. Radiofrequency ablation of liver tumors, microwave ablation, nanoknife tumor ablation, and things that we can do post-operatively or pre-operatively that are called adjuvant therapies, in addition to surgery and cytoreductive procedures, i.e. things like bland embolization, TACE, tumor transarterial chemoembolization, microsphere embolization. Dr. Nutting is going to talk about that. I-131 MIBG therapy, Dr. Campo is a world's expert on that. Biologic response modifiers like Afinitor, Sutent, chemotherapy like Captem, and then the PRRT with the yttrium-90, lutetium, and indium-111. Well, this is the real stuff. These are the numbers, and this is how we set out to do a study. And you can see that we have our Evelos database, whoops, wrong one, Evelos database here, and then we start sorting out people till we end up with 189 patients we operated on. But since some of these people get 2 operations, we evaluated 229 operations. The demographics were extracted from the patient's chart. We went through their op records to review everything. We went over and had our pathologists look at every piece of pathology, including stuff that you brought in from your doc at home. We looked at the survival rates calculated from the date you were diagnosed. And I'm going to show you for the first time, I think, a new way of looking at survival that asks the question, having metastatic neuroendocrine tumors takes how much off of my lifetime? And I'm going to show you that number in a minute. So here we had 189 patients, 200 procedures. As you can see, more women than men, more white people than other races, which is really fascinating because if you look at data, traditionally, white-black ratios are about 50-50. And I've asked Dr. Odoricio, I've asked Dr. Wallen, I've asked Dr. Anthony, I've asked our group, and everybody sees fewer black people than you would expect if the 50% was true. I don't know why that is. It may be racially biased because only more sophisticated people come to us, wealthier people come to us. I don't know the answer to that, but I think it's fascinating. Again, where do our tumors that we cytoreduce, where are they? They're predominantly in the small bowel. The tumor size goes from unknown to multiple tumors, where you saw in the pictures of Dr. Shi that there would be 1 tumor here, and 2 or 3 inches downstream, you'd see another tumor. You saw Dr. Wang allude to, he thought he knew the reason why that happened, and I'll just show you that again, because I think it's such a unique observation. Well, here are the symptoms that people come in with, and it tells you there's a huge difference between what you feel as a neuroendocrine patient and what you see. People have flushing reported 64% of the time, but if you ask their husband or wife who are sitting in the room with it, how often do you see Aunt Minnie or Uncle Fred or your wife or your husband flush? The answer is very rarely. So there's a much bigger perception of flushing than there is a reality. Diarrhea is the biggie. About 74% of the people that we see have diarrhea. A few wheeze, about 10%. And if you add it all up together, diarrhea, wheezing, etc., about 86% of the people we see with widespread metastatic disease have syndrome of at least part of the syndrome. This is a listing of all the surgical procedures that we do. Again, you will see, whoops, wrong one. Yeah. As you will see, the primary group operated by us, and then the people operated elsewhere, and then things like oophorectomies, peritoneal stripping, and nanoknife assistance, etc. So this is the kind of picture that Dr. Wang showed. Again, look at the primary tumor. It's a big lump there that they inject blue dye, and notice that the blue dye starts to trail out of the tumor. Again, that it is really important because that will give you adequate margins. If you cut across the blue line, it's sort of like, what was the kids' game that we all played? That, step on a crack, break your mother's back. Well, if you cross the blue line, bad things will happen to you in the middle of the night. Again, this is a picture of the primary tumor right here. Let me show everybody over here. Here's your primary tumor. Again, the blue dye crosses the ileocecal valve here and then makes a right-hand turn for along the superior mesenteric artery. And this, you have to do a formal right hemicolectomy. You cut here, you cut up here, and you excise all of the lymph nodes in here. And again, if you have a tumor here and it doesn't cross the ileocecal valve, then you're safe to save the ileocecal valve right here. And that's really a major deal. If you didn't pick it up, Dr. Wang said 40% of the people that he operates on, he can save the ileocecal valve. If you ask elsewhere that don't do this, they routinely take the ileocecal valve, and those people have way more diarrhea. Again, this is the mesenteric mass. It's like a roadblock. So as the lymph starts to come up, and the lymph is what has the tumor cells fall back down because they're blocked, and you now have multiple primaries along the small bowel. Well, one of the things that I want to talk about is I hear a lot from patients and patient doctors and anesthesiologists that Dr. Pommier says, give a single dose of medicine of octreotide 2 hours before surgery, and that'll take care of it. Remember, the average surgery that we're talking about is 6.5 to 8 hours. So they gave a 500 microgram bolus, and then they said that was it. And they said, we're going to define a crisis as high or low blood pressure lasting for greater than 10 minutes. And with giving just a single dose, 24%, about 1 out of 4 people had an intraoperative crisis. I don't know about you guys, but that scares the poop out of me. I didn't bring enough underwear for that. And you got to understand, while we talk like this, Dr. Pommier is one of my lifelong friends. When I left Oregon, I left my practice of neuroendocrine tumors to Rod. He was my intern when I first went to Oregon. So Rod, I'm not criticizing the person, I'm criticizing the data. And that's a huge difference that you have to know. Okay, so the octreotide half-life is about 1.5 to 2 hours. So if you give it 2 hours ahead of surgery, and surgery takes 6 hours, that's 8 hours, and that's 4 half-lives. 100%, 50%, 25%, 12%. Okay, that's how half-lives work. And so 3 to 4 half-lives if you give the medicine as a single bolus 2 hours ahead of time. We believe that if you give a bolus and then an infusion through the operation into the recovery room, you're going to do better. And remember the number, 1 out of 4 people have an intraoperative crisis. Hello? Yeah. So we give everybody a bolus and then a high-dose continuous infusion. We initially, a long time ago, started at 200. Now we're at 500 micrograms an hour. We start 2 hours prior to surgery to let the medicine build up. We give it all through the operation and post-operatively, and then we taper it over 4 to 24 hours. Now, if you have a endoscopy, we don't do this. We give a single dose because it's so quick. You won't have to cover somebody for 8 hours. If you do an infusion, you do it on big operations. And I think that's critical. Again, we had 217 patients that had normal anesthesia courses. And as we look, 9 patients met the criteria for a carcinoid crisis. We reviewed all these patients, and we think that 4 or 2% had an intraoperative crisis. And this wasn't a review just by a surgeon. Again, you got to deal the cards off the top of the deck. So we let the surgeons look at it, put the data over here, then let anesthesia, who had nothing to gain from this one way or the other, and had them look at it, and then we went and sat down and sort of had a conference that looked at this. The overall incidence of crisis while receiving intraoperative octreotide was 3%. So Dr. Pommier, single dose, 26% or 25%. Our dose, starting 2 hours, go through the operation into the recovery room, 3%. So I think you know and I know if I have to get operated on ever for a carcinoid, what I'm going to do. I'm going to do the infusion. You have to then ask yourself, if octreotide was a very unsafe drug, you might not do it. But octreotide is the safest drug we've ever met. So it's relatively inexpensive to be covered for that 4-hour, 5-hour period. It's very safe, and it decreases your crisis rate from a fourth down to 1 or 2 out of 100. Okay. So again, surgery and survival rate is a good thing to talk about, but only if you can do it safely. So we went through again and looked at the complications based on a scale by a Dr. Dindo. And this is a classic sort of scale that is done for all kinds of surgical procedures. 51% had no postoperative complications prior to discharge. 39% had minor complications, things like a urinary tract infection, a little bit of what's called atelectasis, kept them in the hospital that we had to clean up their lungs and stuff, and the 30-day postoperative death rate. So we're doing these big, huge, hairy-ass operations, but we're doing them safely, complication-wise, and 3% of the people die. Now, if that's your loved one, gosh, you know, my mom's in this group. I mean, at 90 years old, my mom's in this group. And I mean, obviously you're scared to death that it's going to be one of your family that dies. And, you know, but 3%, when you consider these big operations, is an incredibly safe procedure. Mean survival is about 20 years. Did you hear that? Mean survival is about 20 years from diagnosis. The survival rates at 5, 10, and 20 years are 87, 77, and 41%. Now let me tell you the other part of this is the people who died, who made up the 87, 77, that's death from any cause. You got killed in a car crash, you're dead. I don't know if you died with a neuroendocrine tumor, of a neuroendocrine tumor, but I know you're dead. It's black or white. And nobody can argue these numbers because it can't get worse because dead's dead. Okay? All right, so then the young lady that worked for me, Annie Diebold, who's now a senior in nursing school, said, you know, my sister is an actuarial, works for a life insurance company. Maybe I could get her to help us and we could figure out actuarial survival, like a life insurance company would. If you're a 50-year-old man who smokes and is grossly overweight, you live less long than a man who's 50 years old, who's white, who's normal weight, and doesn't smoke. That's how they figure out how much does smoking take off your life. So we set out to ask the question, how much does having stage 4 carcinoid, well-differentiated midgut, that we cytoreduce you? Dr. Chody talked about R1, R0, complete resection, partial resection, and in our case, serial resection. Come in once, let you heal up, come in and finish the job later. So what we did was we looked at a table, and actually this table is set up by the federal government, and it basically says, what is your race, what is your age, what is your sex, and then put you in 5-year increments. And so we looked at one of our patients, and it was my mom, age 90, white, female. And so we looked in and put her in the right thing. And then we had, from this chart, a knowledge, what if she didn't have the tumor, what would be her life expectancy? So we could now create 2 survival curves. And here's a survival curve from Histologic Diagnosis. And these are the 2 survival curves with and without a neuroendocrine tumor. And as you can see, again, median survival is 300 months or 236 months. Actuarial survival, if you didn't have the disease, is 200 or 300. And so years, it takes 5 years off of your life to have a neuroendocrine tumor, stage 4, if we can cytoreduce you. Guys, I forgive you that if you smoke 2 packs of Winston's a day and were 50 pounds overweight, you're talking about me 7 or 8 years ago, that my actuarial survival, I'd be better off with, losing weight, stopping smoking, and getting metastatic carcinoid. Well, what's happened over the last decade that might account for increased survival? We believe that it's aggressive surgery. You can believe anything you want, but you got to put in there that things have been happening. RAD001, high-dose octreotide that I use like 60 milligrams a month versus 30, PRRT, better biomarker monitoring. The people at ISI have brought you pancreastatin, neurokinin A, octreotide levels, lanreotide levels, better patient educations. People like CCAN, Bob and Marianne, who are up here beating their butts. They don't get money and make money out of doing this. They do this out of the love of why they do it. But you're hearing the experts, and that's going to make you live longer. And the better understanding about how tumors are the same and how they're different. Remember the picture of the dogs. They're all dogs, but they're all different. Everyone in here is a different person and needs a different way of doing things. Again, Irv, I want to give you the raspberry. You're wrong. 43%. You're older than dirt, Irv. You need to get some new studies to publish. Nanettes, 54%. Better than Irv, but way longer that if you get cytoreduced and have an aggressive approach. Everybody in here needs to hear the next slide. Look at the slides. Don't look down, because these next 2 slides are the most important. This is a slow-growing tumor, but it'll kill you deader than a smelt if you ignore it. And research is what we need. Local research guys. Thank you.